Assalamualaikum and a very good day to everyone. We are from Group 7 who would like to present our case study. We are supervised under Dr. Nurul Farhana Jufri. Here is the name list of our group members. Before we move on to the case, here is a short message for you.
Hey guys! To prevent yourself from getting COVID-19, please wash your hands frequently, wear a mask, practice social distancing, and also stay at home. Before we jump into the video, don't forget to hit the subscribe button for more interesting videos soon. Let's get started. 36 years ago, there was a couple who fell in love. They got married and lived a peaceful life. After 1 year, they gave birth to a baby girl called Kajian. Yes, that is me. Since I was a baby, my parents have given me all the best. During secondary school life, I found many changes on my body. For example, development of breasts, acne on my face, menstruation, and the widening of hips, and it makes me worried. But my mom told me that, don't worry girl, you are a big girl now. After graduated from university, I started to work in a company, and I have always been success in my career. Later, I met a man named John. We started our relationship. Finally, we got married at the age of 29. In 7 years of marriage life, I've been trying to conceive a baby, but ending up failed. My period also became irregular and eventually come to a stop. My face have become spotty, acne, and there is increased hair growth at the chin and also above the upper lip. Hence, in order to find out what is happening to me, I consult with the doctor at the hospital, and a biochemistry test was carried out. A panel of doctors is having a meeting to point out what is happening to me. From now on, the panel of doctors will explain to you about what is actually happening to me. Let's find out.
Signs and symptoms. The patient showed symptoms of infertility and irregular period for years. This could be due to menstrual disorder, alteration in hormone level, excessive amount of androgen, aging, and being overweight. The next symptom that the patient showed was waist to hip ratio of 0.90, which is above the normal ratio of 0.85. Hence, she have abdominal obesity. This could be due to excess abdominal fat, which impairs regulation of insulin. The patient also showed symptoms of having spotty skin, acne, increased hair growth above her upper lip and her chin. Excess acne and hirsutism are caused by hyperandrogenism, which is an increase in androgen level. It could be also due to imbalance in the level of FSH, LH, testosterone, and prolactin levels.
One of the symptoms of the patient is amenorrhea, which is the absence of menstrual bleeding. Amenorrhea is normal in prepubertal females, pregnant females, and also postmenopausal female, but it is abnormal to be happen in female apart from the categories mentioned just now. There are two categories of amenorrhea, which are primary and secondary amenorrhea. Primary amenorrhea is a failure of menses to occur by the age of 16 due to the structural problem of female reproductive system and hypothalamic disorder, while secondary amenorrhea, which is a cessation of menses due to lifestyle factors, medication, and also hormonal imbalance. Next, what causes amenorrhea? It could be first due to excessive exercise. Women who participate in activities that require rigorous training, such as ballet and short-distance running, will find their menstrual cycle interrupted. Several factors combine to contribute to the loss of periods in athletes, including low fat of the body, stress, and high energy expenditure. Excessively low body weight, which is around 10% under normal weight, will interrupt many hormonal function in your body, potentially stopping the ovulation. Women who have an eating disorder such as anorexia or bulimia will often stop having periods because of these abnormal hormonal changes. Mental stress can temporarily change the functioning of your hypothalamus, which is the area of your brain that controls the hormone that regulate the menstrual cycle. Ovulation and menstruation may stop as a result, and the regular menstrual period usually resume after the stress decrease. Next will be medication. Certain medication can cause menstrual periods to stop, for example, cancer chemotherapy, antidepressant, allergy medication, blood pressure drugs, and many more. Polycystic ovary syndrome can cause relatively high and sustained level of hormone rather than the fluctuating levels that can be seen in the normal menstrual cycle. Next, hypothalamus and pituitary disorder caused by a non-cancerous tumor in your pituitary gland can interfere with the hormonal regulation of menstruation. Thyroid disorder. Hyperthyroidism or hypothyroidism can cause menstrual irregulation, including amenorrhea. And last will be structural problem of the female reproductive system.
Biochemical test results. For her biochemical test results, the level of luteinizing hormone was increased, follicle-stimulating hormone was normal, sex hormone binding globulin was low, the level of prolactin was increased, testosterone level was also increased, 17-alpha hydroxyprogesterone was normal. Differential diagnosis. There is 5 differential diagnoses: congenital adrenal hyperplasia, hyperprolactinemia, Cushing's syndrome, thyroid syndrome, and polycystic ovary syndrome. This is a table consisting of differential diagnosis, signs and symptoms, and biochemical test results. For congenital adrenal hyperplasia, the signs and symptoms are acne, excess facial hair, irregular period, infertility, amenorrhea, early signs of puberty. For biochemical test results, there will be a mildly elevated 17-alpha hydroxyprogesterone. For hyperprolactinemia, the signs and symptoms are amenorrhea, infertility, irregular periods, lactation, vaginal dryness, and pain in the breast. The biochemical test results showed an elevated level of prolactin. For Cushing's syndrome, the signs and symptoms are acne, excess facial hair, amenorrhea, weight gain in face, collarbone, and back of neck. The biochemical test results showed elevated cortisol level. For thyroid syndrome, the signs and symptoms are amenorrhea, obesity, muscle aches and cramps, goiter, irregular heavy menstrual. For biochemical test results, there will be a elevated level of thyroid stimulating hormone. For polycystic ovary syndrome, the signs and symptoms are acne, facial hair, irregular periods, amenorrhea, infertility, and abdominal obesity. The biochemical test results showed elevated luteinizing hormone, elevated testosterone, sex hormone binding globulin reduced, FSH normal, and insulin resistance. In this slide, we can observe that the patient's signs and symptoms and biochemical test results is similar to the diagnosis of polycystic ovary syndrome. Next question is significance of measuring prolactin and 17-hydroprogesterone 17-OHP. Prolactin was tested to rule out hyperprolactinemia. The patient prolactin within the normal range. High prolactin indicate hyperprolactinemia, while prolactin level usually normal in women with polycystic ovary syndrome. Hypersecretion of prolactin by autotroph cell of the antibiotic cause hyperprolactinemia. So elevated prolactin level during pregnancy for milk production once the baby is born. Apart from the milk productions, elevated prolactin level inhibit release of gonadotropin releasing hormone from the hypothalamus. So this causes decrease in luteinizing and follicle stimulating hormone, which is in result decrease estrogen. So this in women cause stop ovulation and menstruation, which is why there is no menstrual period. So one of the patient symptoms is amenorrhea. Then the 17-hydroprogesterone or 17-OHP was tested to rule out late onset or non-classical congenital adrenal hyperplasia. So the patient normal 17-OHP result means that the patient it is likely doesn't have congenital adrenal hyperplasia due to 21-hydroxylase deficiency. So late onset or non-classical CAH caused by mutation in CYP21A2 gene, and it is inherited autosomal recessive manner. So the mutations lead to deficient level of 21-hydroxylase, which is lead to low aldosterone, low cortisol, and overproduction of androgens. High level of androgen lead to masculinization of female. So one of the patient's symptoms is acne and has growth above lip and chin.
Next is the confirmational diagnosis. In confirming the diagnosis of PCOS, there are a few guidelines that can be followed. In 2003, it is concluded that PCOS are not to be diagnosed with a single diagnostic criterion such as hyperandrogenism or polycystic ovary only, due to the nature of PCOS that develop signs and symptoms as an ovarian function. This is how PCOS is diagnosed based on the guidelines. For National Institute's health criteria, it does not include polycystic ovaries as one of the criteria for diagnosis of PCOS, while both the Rotterdam criteria and Androgen Access PCOS Society criteria includes polycystic ovaries as a feature in order to diagnose PCOS. In 2015, an updated guidelines in the evaluation and treatment of PCOS were released. The new guideline states the diagnosis of PCOS should follow two of the three features, which are chronic anovulation, hyperandrogenism, and polycystic ovaries. The updated guidelines also states that the level of serum 17-hydroxyprogesterone can be used to aid in the diagnosis of PCOS. This is the specification for the criteria. For hyperandrogenism, it can either be clinical hyperandrogenism such as acne, hirsutism, and androgynic alopecia, or it can be biochemical hyperandrogenism, which is elevated serum androgen level that can be measured through the level of testosterone. Then, the menstrual irregularity are based on the irregularity of the menstrual cycles or mid-luteal progesterone with no ovulation. Lastly, specification for the polycystic ovaries on ultrasonography is the presence of more than 12 follicles measuring 2 to 9 mm in one or both ovaries, or the volume ovaries exceeds 10 cm cubic. This is how the polycystic ovary are detected under ultrasound images. Next is the hormonal test that can be done for diagnosing PCOS. Firstly is luteinizing hormone and follicle stimulating hormone. These hormones are essential for reproduction. Elevation of LH and FSH are actually still within the normal range, but with a different LH to FSH ratio. The changes to this ratio could affect the ovulation. Next is testosterone level. Total testosterone or T-testosterone are the amount of total testosterone in the body, including free testosterone or F-testosterone. F-testosterone refers to the unbound testosterone in the body. Elevation of this hormone in women could suppress the menstruation and ovulation. It could also induce physical changes such as hirsutism. Next is progesterones. Progesterones are secreted by corpus luteum after ovulation to prepare the uterine lining for pregnancy. If the progesterone level is high, it is an indication of ovulation had occurred. This test is done because women with PCOS could have signs of ovulation occur, but they will have low level of progesterone due to the egg unable to be released from the ovary. Then, TSH are checked to rule out any thyroid function disorder because underactive or overactive thyroids could cause irregular periods and anovulation. Then, sex hormone binding globulin or SHBG are hormone carriers throughout the body. This helps to regulate hormone level in the body because hormone bound to these proteins are unavailable to be used. When SHBG are low, excess sex hormones are available to be used. In the condition of PCOS, they have low SHBG, which leads to excess testosterone, resulting to changes such as acne, spotty skin, and excess hair growth. Lastly, women with PCOS are often associated with hyperinsulinemia and insulin resistance. Most of the women suffering from PCOS are most likely to be overweight or obese, leading to the development of insulin resistance and hyperinsulinemia. Hyperinsulinemia could induce the excess testosterone production, resulting in anovulation.
Next, we proceed to the hormonal regulation in PCOS. First, let me understand the normal regulation of hormone in female reproductive system. It started with hypothalamus, where hypothalamus will release GnRH. GnRH will induce anterior pituitary to secrete FSH and LH hormone. These two hormones will induce ovary to secrete certain hormone. For the LH will induce TK cells to synthesize DHEA and androstenedione. These two precursor hormones is important in the production of the androgen. TK cells will produce androgen in the form of testosterone and androstenedione. For the FSH will induce granulosa cells to secrete estrogen. In addition of that, DHEA and androstenedione that is secreted by the TK cells will convert into estrogen by granulosa cells. As the follicles undergo maturation, there is a conversion of follicles into corpus luteum, where corpus luteum will secrete progesterone. Progesterone is important in the thickening of the uterus lining as a preparation for the implantation. High level of estrogen will induce negative feedback to the hypothalamus and anterior pituitary, where hypothalamus and anterior pituitary will secrete less GnRH and FSH in response to the high level of estrogen. Some point to be added, such level of LH will induce ovulation to be happen, where the ovum is released from the ovary and ready for the fertilization. This is the whole picture of hormonal involved in the PCOS. Okay, many journals suggested that the causes of the PCOS is due to the hyperandrogenism. Okay, so let me see what are the factors that contribute to the androgenism in patients with PCOS. Okay, one journal suggested that patient with PCOS has problem with GnRH secretion. where the patient with PCOS has high GnRH pulse frequency. This means that the patient has increased secretion of GnRH. Okay, so as we know, GnRH will induce pituitary to secrete FSH and LH. Okay, the problem comes again where the patient with PCOS has responded to the LH more compared to the FSH. So this leading to the condition of high level of the LH compared to the FSH in the blood. So high level, high LH FSH ratio. Okay, as we know, FSH will induce granulosa cells to secrete estrogen, while LH will induce T cells to produce androgen. As we know, the patient with PCOS has high LH, so high LH will induce excess production of the androgen hormone. So these conditions lead to the hyperandrogenism in patients with PCOS. Okay, second, one journal reported that the alteration of the cortisol metabolism is linked to the condition of hyperandrogenism. Okay, the details of this pathway we will see on the next slide. Okay, some other condition that has close connection with PCOS is insulin resistance. Insulin resistance maybe can get from the diabetic mellitus, or maybe patient with obese, or if the patient has the genetic defect. Okay, so somehow people with insulin resistance will induce their pancreas to secrete more insulin, to produce more insulin, leading to the condition of the hyperinsulinemia. High insulin in the blood has direct effect toward the level of androgen in the blood, where high insulin equal to the high androgen in the blood. High insulin has direct effect to the hyperandrogenism, high androgen in the blood. Okay, not only that, hyperinsulinemia also cause the liver to produce less SHBG, sex hormone binding globulin. So, less testosterone is going to bind with the SHBG, resulting to the condition of more free testosterone in the blood. So, we can say that high testosterone in the blood leads to the condition of the hyperandrogenism. Okay, the detail of all these factors we will be discussed on the next slide. Okay, here we will discuss three theories pathogenesis of PCOS, which are due to the alteration in secretion of GnRH, alteration in insulin secretion and insulin action, also alteration in cortisol metabolism. Okay, the first theory is that an alteration in GnRH secretion that lead to the increased LH secretion. We have two reasons to be discussed here. The first one is that patient with PCOS has increased sensitivity of pituitary to GnRH. It means that only a little amount of GnRH is enough to induce anterior pituitary to secrete more LH. So then, journal suggested that there is increase in LH pulse amplitude and frequency in patients with PCOS. So, as we know, excess LH secretion will induce T cells to produce excess androgen that lead to the condition of androgenism, hyperandrogenism. Second reason is that patient with PCOS has increased pulse frequency of GnRH. Journal suggested that this is due to the reduction in sensitivity of hypothalamus GnRH pulse generator towards progesterone hormone. As we know, patients with PCOS having impair in follicles development. So, the follicles cannot convert to the corpus luteum, so that corpus luteum cannot secrete progesterone hormone. Supposedly, low level of progesterone due to the impair of the follicular development will induce hypothalamus to secrete less GnRH. But due to this patient, due to the PCOS, insensitivity of hypothalamic GnRH pulse generator towards the progesterone, so no reduction in GnRH will happen to this patient. So GnRH will be always increased in the blood. Next, second theory is that an alteration in insulin resulting to insulin resistance. First, we should understand that tyrosine kinase receptor will mediate the action of the insulin. Two actions can be happen, which are: first, if there is tyrosine autophosphorylation towards the tyrosine kinase receptor, it will enhance the action of the insulin. Second, if there is a serine phosphorylation of tyrosine kinase receptor, it will inhibit the action of the insulin. So, based on the journal, they suggested that less 50% of PCOS patients have excessive serine phosphorylation of insulin receptor. Mean that serine phosphorylation will inhibit the action of the insulin. So there were two outcomes here. Okay, first, serine phosphorylation will inhibit the signaling of insulin to bring glucose enter the cell. Okay, second, serine phosphorylation will modulate the activity of key regulatory enzyme of androgen biosynthesis, which is P450C17. These enzymes function in the synthesis of androgen hormone. So, we can see that there is increased activity of androgen synthesis. So, we can understand that on how insulin resistance can lead to the hyperandrogenism due to the increase in activity of regulatory enzyme of androgen biosynthesis. Next, alteration in secretion insulin action that lead to the hyperinsulinemia. Okay, let's see on how hyperinsulinemia can lead to the hyperandrogenism. Okay, first, insulin has direct effect toward the liver, where it will inhibit the synthesis of SHBG, sex hormone binding globulin. So, there is less SHBG in blood. Less SHBG in blood causing the sex hormone to be available in blood, including the androgen, which is the testosterone, and also the androgen. So, more androgen and estrogen available in blood. So this condition lead to the hyperandrogenism. The theory to be discussed here is an alteration in cortisol metabolism that can lead to PCOS. Okay, first, journal suggested that some patients with PCOS have increased activity of 5-alpha reductase in the liver. So, this enzyme will decrease the activity of cortisol metabolism by increased inactivation of cortisol. So here cortisol will be inactive, not active. So our body will do compensation mechanism. Okay, where the anterior pituitary will secrete more ACTH in order to maintain the serum cortisol level in blood. So ACTH will induce adrenal gland to produce cortisol. Other than that, the precursor hormone of androgen, which is DHEA, also will be synthesized. So increase the synthesis of precursor hormone, which is androgen, will increase the production of the androgen, specifically androgen that produced by the adrenal gland. So increase in adrenal androgen can lead to the condition of hyperandrogenism. Hyperandrogenism. So the condition of hyperandrogenism can be the causes of the PCOS.
Next, let's have a look on the main causes of amenorrhea in PCOS. Amenorrhea in PCOS is caused by hyperandrogenism. Hyperandrogenism can be caused by three factors. First will be the slightly high level of 17-hydroxyprogesterone produced by the follicle, which inhibit the production of estrogen. This will then leading to a decrease in estrogen-mediated negative feedback of gonadotropin-releasing hormone in the hypothalamus. This is then stimulate the release of luteinizing hormone from the anterior pituitary that induce the increase of testosterone production. Hyperandrogenism can also be caused by low level of sex hormone binding globulin. The reduced serum level of sex hormone binding globulin making the binding of testosterone to decrease, hence resulting more free testosterone level in the serum. Lastly, it will be the high level of luteinizing hormone. Polycystic ovary have a thicker layer, and the thicker cells derived from this ovary secretes excessive androgen in vitro under basal condition or under the stimulation by the luteinizing hormone.
Next, we will proceed to the risk factor of PCOS. There are 4 risks of medical problems associated with PCOS. The first is insulin resistance, second is metabolic syndrome, third is obesity, and fourth is cardiovascular disease. The first is insulin resistance. Insulin resistance occurs when cells don't respond to insulin, cause the glucose level in the blood increase. Then, insulin level high or known as hyperinsulinemia. Insulin is able to inhibit hepatic sex hormone binding globulin, thus cause decrease in SHBG. Hyperinsulinemia also causes abnormal folliculogenesis and also elevated luteinizing hormone. Abnormal folliculogenesis will increase the abnormal productions of androgens. This will lead to the hyperandrogenism and oligo-ovulation and anovulation, and then cause PCOS. Next is metabolic syndrome. Polycystic ovarian syndrome is linked to the same cluster of events that promote the metabolic syndrome. Metabolic syndrome is a chronic low-grade inflammatory condition in which adipokines play a major role. Adipocytes are actually considered as endocrine cells that synthesize and release molecules, which is adipokines, that play an endocrine or paracrine role, such as adiponectin, atrial natriuretic peptide, leptin, resistin, and tumor necrosis factor alpha, TNFA. Isolated adipocytes from women with PCOS express higher mRNA concentration of some adipokines involved in cardiovascular risk and insulin resistance. On the other hand, metabolic syndrome is a constellation of metabolic disorders which include mainly abdominal obesity, insulin resistance, diabetes, cardiovascular disease, and many more. After that, we will proceed to the obesity. Obesity, particularly the abdominal phenotype, may be partly responsible for insulin resistance and associated hyperinsulinemia in women with PCOS. Therefore, obesity-related hyperinsulinemia may play a key role in favoring hyperandrogenism in these women. Insulin is able to inhibit hepatic sex hormone binding globulin (SHBG) and thus cause decrease in SHBG. Hyperinsulinemia and the increased responsiveness of the ovarian theca to insulin cause an increase in the level of free androgens. Hyperandrogenemia increase a person's predilection for central adiposity and worsen the insulin resistance and dyslipidemia. Estrogen level also increase. Obesity also causes hyperactivity of the HPA axis, and all these things happen will lead to PCOS. The last one is cardiovascular disease. The hypertrophic adipocytes secrete various molecules, including inflammatory markers and adipokines, which may in turn determine the development of insulin resistance. An increase of hepatic production of hsCRP, an increase of ovarian and adrenal androgen production, which may further aggravate the central adiposity distribution and may even directly act to determine vascular injury. It is not yet clear if androgen excess, which is the marker of PCOS, has a direct influence in the development of atherosclerosis and preclinical cardiovascular disease. For the treatment of polycystic ovarian syndrome, we are going to treat Miss Jane according to her symptoms that she is suffering. So the first one is infertility. As we all know, Miss Jane is having difficulty in trying to conceive a baby. In order to treat Miss Jane's infertility, firstly, we are going to prescribe her with clomiphene or clomid. This oral anti-estrogen medication is going to help Miss Jane for ovulation, and it must be taken during the first part of menstrual cycle. If Miss Jane don't become pregnant using clomiphene, we might recommend her to add metformin. And based on the patient history, we discovered that Miss Jane has high waist to hip ratio, and this may indicate that Miss Jane is suffering from insulin resistance. So by adding metformin, this metformin can help to improve insulin resistance and lower insulin level. Third one is obesity. So Miss Jane has high BMI ratio, which indicates that she is obese. So in order to overcome obesity, she needs to modify her lifestyle. She needs to exercise more and eat healthily because this lifestyle modification can help her to manage insulin levels and also lower the risk of developing diabetes. Next one is acne. To treat acne, we prescribe her with topical cream. An example of topical cream are benzoyl peroxide and also antibiotics. And the last one is hirsutism. The best way to reduce hair growth on the upper lips and chin, we might recommend Miss Jean to undergo electrolysis procedure, where a tiny needle is inserted into each hair follicle and the needle will emit a pulse of electric current to damage and eventually destroy the follicle. Besides that, birth control pills will also help to decrease the androgen production that can cause excessive hair growth.
There are two ways in preventing PCOS. The first one is through dietary and the second one is through lifestyle. In dietary aspect, the first one is to eat food that are free from artificial sugars, hormones, and preservatives, as this will cause endocrine system to better regulate the blood sugar. The second one is to balancing carbohydrates and protein intakes, as protein will stimulate body to produce insulin, and unprocessed high-carb food can improve insulin sensitivity. The last one is through decaf alternative, as caffeine consumption may be linked to changes in estrogen levels and hormone behavior. Through lifestyle, the first one is to maintain healthy body weight. This will reduce risk of PCOS. Second one is through healthy exercise. Too much exercise can disrupt hormones. And lastly, reduce stress and get enough sleep. And these are the references used to make this presentation. And thank you.